Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your nears and dears to help them in their preparation of MBBS course as well as NEET PG. Also, please don't forget to press the bell icon below to get my videos regularly. Last time, we had learned the surgical aspects of Ascariasis. Today's discussion is about another nematode, the filarial parasite. These invade subcutaneous tissues and the lymphatics and cause diverse surgical problems. Filarial worms are tissue-dwelling nematodes. There are 8 filarial species that infect humans. Out of these, Wuchereria bancrofti, Brugia malai, Onchocerca volvulus and Loa loa cause most cases of symptomatic filarial infections. The most common invader is Wuchereria bancrofti, followed by Brugia malai and Brugia timori. Lymphatic filariasis is caused by Wuchereria bancrofti, Brugia malai and Brugia timori. These worms infect the lymphatic system and disrupt fluid balance and immune function. These parasites are transmitted by a specific species of mosquito. Culex, Anopheles and Aedes are vectors for Wuchereria. Mansonia, Anopheles and Coquilletteria serve as the vectors of Brugia species. The source of infection is a person having circulating microfilariae in the peripheral blood. Microfilariae are 170 to 320 micrometer in length and 6 to 10 micrometer in thickness. Microfilariae was first demonstrated in human body by Lewis in Kolkata in the year 1872. In established filarial disease means in late obstructive stages, microfilariae are not found in the blood. After a vector mosquito bites a person carrying microfilariae in peripheral blood, the microfilariae develop into new infective larvae. The vector mosquitoes harbor an intracellular endosymbiont gram-negative rickettsia-like bacteria known as Wolbachia. Wolbachia bacteria are also present intracellularly as an endosymbiont in larval stages of all human filariae except Loa loa. Wolbachia are required for nematode development and reproduction. Antibiotics that eradicate Wolbachia impair nematode survival and fertility. The main inflammatory injury to the lymphatics and pathologic changes are caused by adult worms, not by microfilariae. Recent studies have demonstrated that the endosymbiotic Wolbachia bacteria, rather than the nematode, is the main cause of acute inflammatory changes in lymphatic filariasis. Wolbachia are required for adult worm development and reproduction. Antibiotics that eradicate Wolbachia impair worm survival and fertility. Lipopolysaccharide endotoxins released by adult worms cause lymphangitis, leading to lymphangiectasia, lymphatic destruction, and the chronic manifestations like lymphedema and hydrocele. Inflammation of the spermatic cord, epididymis, and testis is also common. Adult worms are found in efferent lymphatics and sinuses of lymph nodes. They cause lymphatic dilatation and thickening of its walls. The lymphatics become tortuous and damaged, and their valves get incompetent due to infiltration of plasma cells, eosinophils, and macrophages in and around the infected vessels, as well as due to endothelial and connective tissue proliferation. Hard or browny edema develops in the overlying skin due to lymphedema, chronic stasis, and connective tissue proliferation. The lymphatic vessel remains patent as long as the worm remains viable. The death of the worm leads to the formation of granulomas and fibrosis around the dead adult parasites through a Th1-mediated cellular immune response. Immune responses to the dead filarial worms cause damage to the lymphatic system. Hypersensitivity to microfilariae in the lungs causes tropical pulmonary eosinophilia. In this process, interleukin-4 and interleukin-5 are secreted by filaria-specific Th2 helper T cells, leading to a stimulation of IgE and eosinophils respectively. It is a humoral immune response. Eventually, lymphatic obstruction develops despite collateral formation. In chronic filariasis, there is persistent briny lymphedema of the extremities, a scrotum, penis, or vulva. In severe and long-standing infections, there develops tough subcutaneous fibrosis and epithelial hyperkeratosis termed elephantiasis. In the skin, the epidermis becomes thickened and hyperkeratotic due to dilation of dermal lymphatics, widespread lymphocytic infiltrates, and focal cholesterol deposits, a condition known as elephantoid skin. Key pathological features in lymphatics and lymph nodes are mild inflammation, intense eosinophilia, hemorrhage, fibrin deposition, and granulomas. The dilated lymphatics develop polypoid enfoldings. Key pathological features in scrotum are elephantoid skin, hydrocele fluid containing cholesterol crystals, thickening and calcification of the tunica vaginalis, and recurrent funiculoepididymitis. Key pathological features in lung disease or tropical eosinophilia are epithelioid granulomas known as Meyers-Kauvenar bodies. Typically, lung disease patients do not show other manifestations of filarial disease. The host's immune response to both living and dead parasites as well as to the endosymbiotic bacteria Wolbachia plays a crucial role in filarial pathology. The clinical incubation period of filarial infection is usually 8 to 16 months, but may be longer. Worldwide, filariasis is the most common cause of long-term disability after leprosy. Males are usually affected because females are less prone to mosquito bites due to their more covered bodies. The filarial diseases include asymptomatic microfilariae, acute adenolymphangiosis, dermolymphangioadenitis, recurrent lymphadenitis, chronic lymphadenitis with swelling of the lymph or scrotum or vulva, and tropical pulmonary eosinophilia. In endemic regions, a great majority of infected individuals have few obvious clinical manifestations of filarial infection despite the presence of circulating microfilariae in their peripheral blood. In acute adenolymphangiosis, there are episodes of high fever with retrograde lymphangitis and lymphadenitis and transient local edema. Retrograde lymphangitis refers to the inflammation spreading in the opposite direction to the normal lymph flow. Regional lymph nodes are often enlarged and lymphatic channels become indurated and inflamed. Concomitant local thrombophlebitis may occur as well. Occasionally, in thin persons, adult worms may be felt subcutaneously. In endemic areas, another type of acute disease, dermolymphangioadenitis, is seen, characterized by high fever, chills, myalgia, and headache. In this, there are edematous inflammatory plaques on the skin, vesicles, ulcers, and hyperpigmentation. Entry lesions are seen especially in the interdigital area. In Brugian filariasis, a solitary abscess may form along the involved lymphatic tract and may rupture subsequently. The upper and the lower extremities may be involved in Bancroftian and Brugian filariasis, but the genitalia are involved almost exclusively in Wuchereria bancrofti infection. Chronic phase begins after repeated acute attacks over several years. Lymphatic obstruction leads to massive lymph size, a scrotal or vulval edema. Obstruction to the subcutaneous lymphatics causes a skin thickening or elephantoid skin. This looks like the PUD orange appearance of breast cancer. Secondary streptococcal skin infections may occur time to time, causing cellulitis, weeping shiny skin, and tiny abscesses. Recurrent lymphangitis attacks cause fibrosis of the lymphatic channels, resulting in grossly swollen lower limb with thickened skin, a condition known as elephantiasis. Condition may be bilateral and then it is often associated with a scrotal and penile elephantiasis, thick-skinned scrotum, folliculitis, epididymitis, scrotal pain, and hydrocele develop in scrotal filariasis. If there is obstruction of the retroperitoneal lymphatics, increased renal lymphatic pressure leads to rupture of the renal lymphatics and chyluria. Chyluria is usually intermittent and most prominent in the morning. Chylous ascites may also develop. When lungs are affected, the disease is mild, causing dry cough, a condition referred to as tropical pulmonary eosinophilia. It is the result of the host response to microfilariae. It is seen mainly in India. Typically, lung disease patients do not show other manifestations of filarial disease. A definitive diagnosis needs detection of the parasites in the blood and hence can be difficult. Adult worms residing in lymphatic vessels or lymph nodes are usually inaccessible. Microfilariae can be found in blood, in hydrocele fluid and occasionally in other body fluids. Knott's concentration technique is a standard method used to detect microfilariae in blood samples. The timing of blood collection is crucial. It should be based on the periodicity of the microfilariae in blood. In India, they show a nocturnal periodicity. Microfilariae are seen in large numbers in peripheral blood only at night between 10 pm and 4 am. Newer tools for diagnosis are ultrasound, lymphoscintigraphy, circulating filarial antigen assays, and PCR. Two circulating filarial antigen tests are the most widely used method for detecting circulating Wuchereria bancrofti antigens in the peripheral blood with or without microfilariae. These are an enzyme-linked immunosorbent assay and a immunochromatographic rapid card test. The circulating filarial antigen tests detect active Wuchereria bancrofti infection and is useful in monitoring response to therapy also. It detects antigens released by adult worms in the blood. The test can be performed at any time of the day. Both methods are 90 to 100% sensitive and about 100% specific. There are currently no tests available for detecting circulating antigens of Brugian worms. Polymerase chain reaction based detection of DNA of Wuchereria bancrofti and Brugia malai in blood are also available. Examination of the scrotum, the lymph nodes, the breast in female patients with high frequency ultrasound and Doppler techniques may identify motile adult worms within dilated lymphatics. The distinctive movement of live adult worms within the lymphatic vessels has been termed as filarial dance sign. Lymphoscintigraphic nuclear imaging of the limbs reliably demonstrates lymphatic injuries in both subclinical and clinical cases. However, as of now, it is mainly a research tool. Active lymphatic filariasis is defined by microfilariemia, antigen positivity, and adult worms on ultrasound. Marked eosinophilia and elevated serum IgE and IgG4 support the diagnosis of active lymphatic filariasis. However, there is an extensive cross-reactivity between filarial antigens and antigens of other helminths. Hence, mere seropositivity cannot be equated with active infection, especially in endemic areas. Acute adenolymphangitis of filariasis must be distinguished from thrombophlebitis, infection, and trauma. Retrograde or descending spread is a characteristic feature that helps distinguish filarial lymphangitis from ascending bacterial lymphangitis. Chronic filarial lymphedema must also be differentiated from postoperative scarring, trauma, chronic edematous states, lymphedema of malignancy, and congenital lymphatic system abnormalities. Silicates absorbed from volcanic soil can also cause elephantiasis. This elephantiasis is known as podoconiosis or non-filarial elephantiasis. The drug of choice for the treatment of active lymphatic filariasis is diethylcarbamazine, 6 mg per kg orally administered daily for 12 days. It has both macro and microfilaricidal properties. Side effects of diethylcarbamazine treatment include fever, chills, arthralgias, headaches, nausea, and vomiting. Most of these adverse effects are due to the host response to dying microfilariae. Treatment with diethylcarbamazine is very effective in the early stages, before the gross deformities of elephantiasis have developed. Albendazole 400 mg twice daily by mouth for 21 days also has macrophylaricide or adult-killing efficacy. Targeting the intracellular Wolbachia has emerged as a promising strategy for treating lymphatic filariasis. Oral doxycycline can kill Wolbachia, leading to the sterilization and eventual death of the adult worms. Regimens that combine single doses of albendazole with either diethylcarbamazine or ivermectin have a good microphylaricide effect and are used in lymphatic filariasis eradication public programs in some countries. Early treatment of asymptomatic microfilariae is recommended to prevent further lymphatic damage. For acute adenolymphangitis, supportive treatment with antipyretics and analgesics is recommended, as well as is antibiotic therapy if secondary bacterial infection is suspected. Treatment with diethylcarbamazine is also recommended for microfilaria negative carriers of adult worms. In chronic disease, good hygiene, prevention of secondary bacterial infection and physiotherapy are recommended, and antifilarial drug treatment should be reserved for individuals who have evidence of active infection. A 6-week course of doxycycline provides improvement in filarial lymphedema irrespective of disease activity. Hydrocele is managed surgically by the usual operation of excision and eversion of the sac with, if necessary, excision of redundant skin. Operations for reducing the lymph size is rarely successful. In highly endemic areas, mass drug administration is the current approach to control and eliminate lymphatic filariasis. In this approach, diethylcarbamazine is administered to everyone in the community, irrespective of whether they have or do not have microfilariae, disease manifestations, or signs of infection, except to children under 2 years, pregnant women, and seriously ill patients. Single dose of diethylcarbamazine citrate and albendazole is administered every year for 5 years or more to the eligible population to interrupt transmission of the disease.